Hello again. I'm David Luce, a faculty member in integrated biology and pharmacology, and I'm going to talk to you today about two classes of anti-inflammatory drugs. Seems fairly reasonable since you've spent an entire week talking about inflammation. And although we don't normally talk about the pharmacology of specific drugs in foundations, I think this would be a great time to introduce the classes of drugs that you will use to treat inflammation, because inflammation probably will be part of virtually every one of the modules that are forthcoming. It's associated with cancer, it's associated with heart disease, it's associated with neurodegenerative diseases. And so the drugs that are of some use, I think, are really quite important to discuss. So I'm not really going to talk about all of the players associated with inflammation. You've already heard a lot about chemokines and cytokines and various inflammatory molecules. But some of the most important of those molecules really are the prostaglandins, and they, in fact, are the class of molecules that we can do something about pharmacologically. So I'm really going to focus on the prostaglandins and prostaglandin derivatives, which in general are called eicosanoids. They're all derived from a C20 carbon, arachidonic acid, and then they get metabolized in a variety of ways. And it's really the metabolism that we can alter with respect to the pharmacology. So if there's one slide in this talk that you really need to remember, it's this one. This is the biosynthesis of eicosanoids. Eicosanoids basically all start from fatty acid precursors that are embedded in phospholipids in the plasma membrane, which basically release arachidonic acid via the action almost exclusively, but not totally, via the action of phospholipase A2 in the cytosol. And basically there are 3 or 4 pathways that released arachidonic acid gets metabolized into active components. There's one pathway that's important in the kidney and important in some other tissues I'm not going to talk about too much, that's mediated via CYPs, that is the cytochrome P450 group of enzymes. And you make epoxides in 19 heats and 20 heats, which are important for renal function and important for some vascular function, but we really can't target that pathway. This pathway, the so-called cyclooxygenase pathway, takes arachidonic acid and makes 2 intermediate precursors to the prostaglandins, that is PGG2 and PGH2. Just sort of remember that they're precursors of prostaglandins. And then the PGH2 is the immediate precursor, and in a tissue-dependent fashion. If you're a platelet, you take PGH2 and you make thromboxane via the action of thromboxane synthase. If you're a fibroblast or a bone cell or a cartilage cell or even a lung cell, via the action of very specific prostaglandin synthases, you make prostaglandins, and the ones that we know the most about are prostaglandins A through J. And if you happen to be an endothelial cell, you have an enzyme called prostacyclin synthase that takes the same precursor, PGH2, and makes PGI2, which is also called prostacyclin, which is an important molecule within the lung and within the vasculature. Now you'll learn when we talk in the pulmonary module about the action of some of the leukotrienes and related compounds, again, that are derived from arachidonic acid, but the enzymes involved are different, and they're the lipoxygenase enzymes, which make the leukotrienes, which are really important in asthma. And we'll see that the pharmacology of this pathway is important. Actually, interruption of the metabolism in this pathway is really quite important when we talk about asthma. And you don't need to know structures, but I like to paint a picture, and so you'll have this to think about. They're really all C20 derivatives. They're fatty acids with saturated or unsaturated side chain, and really it's this A ring that differs between the various classes of prostaglandins. Prostacyclin is a little bit different because it's in a trans configuration, but again, it's a C20 derivative, albeit with a somewhat different structure. Now, the enzymes that are responsible for the production of PGG2 and PGH2, the immediate precursors of all of the prostaglandins, The two enzymes are the cyclooxygenases, and there really are two isoforms. It was a little confusing initially when these enzymes were discovered because they are very, very similar. As you can see, they're virtually identical except for a little difference here on the carboxy terminus, and that made the initial investigations into the identity of the two enzymes somewhat difficult. But they really are two enzymes. They have exactly the same enzymatic capability. That is, they both produce PGG2 and PGH2. But the regulation of these two enzymes is really quite different. COX-1 can be thought of as more or less constitutive. It's really important in the gastrointestinal tract, it's important in the kidney, it's important in the brain, and it's expressed at low levels virtually all of the time in all of those tissues. Now, cyclooxygenase type 2, or COX-2, is a different enzyme with respect to its regulation in that its basal expression in virtually every tissue of the body is very low, but upon initiation of the whole inflammatory process that you've learned about, COX-2 is highly induced. In fact, it was initially discovered based on its induction profile, where it's induced greater than an order of magnitude upon inflammation in inflamed joints and in other inflamed tissues. Now, if you think about inflammation, we have to think about, well, gosh, inflammation is white cells coming in, and they release a bunch of cytokines, and that turns on prostaglandin biosynthesis by surrounding tissues and by lymphocytes, and those prostaglandins cause release of more cytokines. How the heck do you limit the extent of an inflammatory reaction? It turns out that one of the classes of prostaglandins that get made during inflammation are called the lipoxins and the related resolvins, and those molecules actually have potent anti-inflammatory activities. I'm not going to talk about too much of those because there's no pharmacology associated with them, but I just want you to appreciate that, in fact, during the inflammatory process and the production of prostaglandins, that the production of anti-inflammatory prostaglandins, the stop signals, are also produced. And it's that sort of balance, that wonderful homeostatic balance that you almost expect in biology is reflected in the biology of inflammation. Now, how do prostaglandins work? You don't need to memorize this list, certainly, but I want you to appreciate that every one of the kinds of prostaglandins that I've talked about, including prostacyclin, prostaglandin I1, thromboxane, and all of the prostaglandins A through J, have very specific receptors that are coupled to signal transduction pathways that you, by and large, have learned about. Most notably, increases and decreases in cyclic AMP, or increases and decreases in calcium and inositide triphosphate metabolism. Now, what happens with these prostaglandins? Let's talk a little bit about the physiology before we talk about the pharmacology. So I've already described for you that from membrane phospholipids via the action of phospholipase A2, you get arachidonic acid, which is acted on either by COX-1, prostaglandin synthase 1, or COX-2, prostaglandin synthase 2. And those precursors are acted on via tissue-specific isomerases, and you make exactly the molecules that I talked about, prostacyclin, thromboxane, and a variety of relatively tissue-specific prostaglandins. What do? In the endothelium, prostacyclin and the kidney and the platelets in the brain really regulates blood flow. It's also a very important mediator in neural tissues of pain. Thromboxane, again, expressed almost exclusively in platelets, causes changes in contraction of smooth muscle cells and is responsible for starting the aggregation reaction in blood vessels. Prostaglandin in the D series are very important in the airways, and they're in mast cells. They're in airways, they're in the brain, also in part responsible for pain transmission. The most common and probably the most abundant prostaglandins are those in the E series. They're very important in the gut, in the brain, the vascular smooth muscle cells, and somewhat in platelets, not quite as important as thromboxane in platelets, but very important. And prostaglandins in the E series are very important in modulating pain, and we'll talk about that shortly. Prostaglandins in the F series are really important in the uterus, where they control myometrial tone, that is the contraction, the level of contraction of the myometrium. Important in the airways, important in vascular smooth muscle cells. Actually, and important for making aqueous humor within the eye, and that's a pharmacologic application we'll talk about. Okay, more specifically, I've just summarized in this slide the physiologic roles of the eicosanoid. So PGE basically is a vasorelaxer. It causes increases in blood flow, and I'll let you read the rest. It does have diuretic action. Prostaglandin in the F series cause vasoconstriction, quite the opposite of their friend PGE. PGD is important in mast cells. It participates in the allergic response and in bronchoconstriction, potentiates pain. PGI2 is one of the most potent vasodilators that we have. It inhibits platelet aggregation, and it potentiates pain as well. Thromboxane, that is the most potent vasoconstrictor that's released by platelets, and it basically starts the entire platelet release reaction with release of serotonin and all the other things that are released from platelets. And the leukotrienes are molecules that are very potent chemoattractants, and they directly cause bronchoconstriction. So I think if we're talking about the pharmacology of inhibiting eicosanoid production, you can almost predict what's going to happen if you inhibit eicosanoid production, if you know something about the physiology of what's going on and the normal physiologic roles of the eicosanoids. So again, I'll just summarize this and then point to the pharmacology as we go through this. So again, membrane phospholipids are the source of arachidonic acid, which is created and metabolized by phospholipase A2. That's inhibited by the glucocorticoids. We'll talk about that at the end of the reaction. Arachidonic acid can be metabolized via the cyclooxygenases into the compounds that I've been talking about, and it's the cyclooxygenases, both COX-1 and COX-2, that are inhibited by the non-steroidal anti-inflammatory drugs, stuff like aspirin and ibuprofen, etc. The lipoxygenase pathway is inhibited by a series of compounds that, logically enough, are called lipoxygenase inhibitors, or leukotriene receptor antagonists. But again, there are specific inhibitors of this pathway that are important, mostly for asthma. Now let's talk a little bit about prostaglandins in pain. I doubt there is a single one of you that hasn't taken ibuprofen or aspirin or naproxen because you had a headache. Well, how the heck do prostaglandins modulate pain transmission, either from your dura when you have a headache, or from a joint where you have a sprained ankle or you've twisted your knee or something like that? So the pathways are all basically identical, and the immediate stimulation, some noxious stimuli shown by this large arrow here, causes changes in the metabolism of largely calcium, but a variety of other mediators, and that calcium activates a channel that's called the TRP channel, which allows some of that calcium to enter a sensory neuron. Again, we're talking mostly about the non-myelated, very small neurons. And in addition to the noxious stimulus, which could be a burn or a needle prick or a cut or what have you, there's the release by that damaged tissue of prostaglandins. There's the release of bradykinins. There's the release of a whole bunch of other substances that interact with those small neurons. Those small neurons are the immediate signal that causes the transmission, and the decrease part of the mechanism by which prostaglandins diminish pain is by decreasing prostaglandins really at step one of the whole process, that is, at the site of the painful stimuli, where they decrease the initial transmission of the pain signal. That is, in the primary hyperanalergesia, prostaglandins themselves increase the magnitude of stimulation, and inhibition leads to a decrease in the initial primary component of pain transmission. In the spinal cord, there's a whole series of neural pathways that we won't talk about too much, but there are GABA neurons that are potently inhibitory, and prostaglandins decrease those GABAergic inhibitory signals, And so you can appreciate that if you inhibit prostaglandins, you will decrease these inhibitory signals and you will increase pain transmission, right? Central hyperalgesia, there's a phenomenon that I'm sure all of you have experienced, and that is that prostaglandins produce this phenomenon called allodynia, and that's when a normally non-noxious stimuli causes you pain. You feel that typically, when you're coming down with the flu and everything is kind of achy and every kind of hurts. Well, that's allodynia. So you're sensing pain where there really isn't a typically painful stimulus, and that's really prostaglandin mediated. And so there are 3 steps in pain transmission and pain sensation that are regulated by prostaglandins, and drugs that interfere with prostaglandins interfere with pain at all 3 of those levels. Another important thing that we haven't touched on a lot are the actions of prostaglandins in fever. I'm sure everyone in this room or everyone listening to this presentation has taken a prostaglandin inhibitor to reduce fever. The mechanism of fever is pretty well worked out. Exogenous pyrogens, typically from a virus or from cytokines in response to another noxious stimuli, causes the release and activation of toll-like receptors 4. Those activate a variety of other cytokines from a variety of other cell types, and the release of cytokines that you've talked about this week, IL-1, IL-6, and TNF-alpha, are the most important. Those agents act, IL-1, IL-6, for instance, via 2 pathways. One is the so-called fast response pathway, whereby IL-1 causes an increase in the release of ceramide and an increase in thermogenesis and an increase in temperature. And the second, slower response, taking 30 minutes or so, is increased COX-2, which causes increased pre-GE2 and activation of one of those receptors I've talked about. And really the afferent output from any of these pathways, the ceramide pathway or the prostaglandin pathway, is shivering, stimulation of thermogenesis within beige adipose tissue, and a change in sweat gland metabolism, all of which causes you to increase body temperature and leads to the febrile response. Okay, so that's the response. Let's talk about inhibition of this pathway in general. So non-steroidal anti-inflammatory drugs, NSAIDs, are about a $15 billion market. We're all aware of the over-the-counter market, and there's actually a very robust prescription market, which basically are the same drugs, albeit at somewhat higher concentrations, and sometimes with a mixture of components if analgesia is the target. All of the NSAIDs that I'm going to talk about inhibit cyclooxygenases. Now, they do it 2 different ways, so we'll talk about that at some length, but I really want you to appreciate that the target is the cyclooxygenases. All of the non-steroidal anti-inflammatory drugs have analgesic, antipyretic, and anti-inflammatory activity. All of them can inhibit platelet function, and all of them can cause premature closure of the ductus arteriosus and increase postpartum hemorrhage. And those are things we need to pay attention to when we think about treating a pregnant woman with these compounds. Now, I have to get up on my soapbox for just 1 second and talk about risk versus benefits of nonsteroidal drugs. The short-term relief of pain with nonsteroidals is well established. I mean, clearly, if you have a backache or a slightly sprained ankle or something and you take for a few days nonsteroidals, the benefit is clear and is very well justified. Where one really needs to begin to appreciate the risk associated with these drugs is really in chronic use. And those basically are patients with osteoarthritis or rheumatoid arthritis, where you're taking very high concentration of these drugs for years. And there's been a series of very good studies, and they haven't been repeated since about the year 2000, but the results are perfectly clear. Celecoxib or naproxen, this is the prescription name of naproxen, basically reduced pain by about 10% on a subjective pain in a knee pain test. Rofecoxib reduces pain in patients with osteoarthritis by about 7%. Okay, so we'll reduce pain by 7 to 10% or so in patients that are taking these drugs for a long time. Now, the risk of that is not insignificant. Nonsteroidals are associated with about 100,000 hospitalizations annually. 100,000 hospitalizations annually. Now, it's a little hard to take that to the next step, but nonsteroidal anti-inflammatories are associated with about 8,000 deaths annually. Now, I would argue that that makes this class of compounds the most dangerous drugs on the market. Now, on a pill-by-pill basis, they're not the most dangerous, obviously, but there are so many millions of patients taking so many millions of doses that this, in fact, needs to be appreciated as a very risk-fraught group of compounds. And most of those are caused by serious GI and serious non-GI adverse effects that leads to bleeding and obviously can lead not infrequently to death. And there also are some risks associated with nonsteroidal use that's associated with reduction in normal wound healing. It actually slows fracture repair. And there's an important role of prostaglandins in the kidney, which are interfered with when one takes nonsteroidal anti-inflammatory drugs, and salt retention and hypertension are some fairly important side effects that are associated with these drugs. And for those reasons, and an increasing concern of the risk of cardiovascular disease, which we'll talk a little bit about in this presentation, all of the nonsteroidals from aspirin on down have the fouling black box warning, and I'll let you read that at your leisure. But again, it's associated with cardiovascular and gastrointestinal risk. Now, we really have to talk some specifics about drugs, although we've talked really about the basics already. But I'm going to talk about these 6 classes of drugs in this nonsteroidal discussion. Talk about salicylates, that goes back to Hippocrates, so it's a couple thousand-year-old drug, which is aspirin, sodium salicylate, and sulfasalazine are the specific salicylates that are on the market and used clinically. The indole acetic acid includes indomethacin, which you may have heard about, a very potent nonsteroidal. Diclofenac and atodolac, 2 drugs that are increasingly being used clinically. Propionic acids, which everybody has probably taken, including ibuprofen and naproxen. Oxycams, phenamates, are really mostly used in an inpatient setting. They're very useful and very powerful nonsteroidals, but they're typically not given very often because of the increased use in the first 3 classes. And then we come to these Darrow-substituted compounds. These are the so-called COX-2 specific inhibitors, which we'll talk about. They came on the market about 10 years ago or 15 years ago. 2 of the 3 have been removed, and I'll talk about reasons that they have been removed. But Celecox remains on the market. So these are the structures of salicylates, very simple compound. So this is aspirin. This is salicylic acid, the basic backbone, and this acyl group that's really quite important. And just remember in the back of your mind this acyl group coming off carbon 2. The rest of these are sort of derivatives of carboxylic acid, and you don't need to remember the structure, but just remember these are very small molecules that basically have a benzene ring and then some other stuff associated with it. What you do need to remember is the mechanism of action. So this is one of the cyclooxygenases, and it could be COX-1 or COX-2. It doesn't make any difference what my picture is talking about. But there's a serine in the active site of those cyclooxygenases. And what aspirin does is that acid to that acyl group basically is transferred non-covalently to that serine group, and that makes for a completely inactive cyclooxygenase. So aspirin causes an irreversible change in a serine that blocks the active site, and that happens both on COX-1 and on COX-2. Now, other salicylates have anti-inflammatory activity, but they don't cause this covalent acylation of COXes, and that's probably mediated by a non-covalent modification of enzymes, similar to some of the other nonsteroidals we'll talk about. Everybody has probably heard of the use of low-dose aspirin for cardiovascular disease. It's important to note that aspirin causes irreversible inhibition of both COX-1 and COX-2. So think about the physiology that I described. In platelets, this causes loss of thromboxane. If you lose thromboxane, platelet activation and platelet aggregation is reduced. If you use a low enough dose of aspirin, you minimize GI adverse effects while having still an impact on platelets because platelets in the bloodstream are exposed to the highest concentration. And really, the clinical data is quite clear. There's a reduction in both mortality and both acute and prophylactic use of low-dose aspirin in cardiovascular disease. The indole acetic acids are the second class of nonsteroidal anti-inflammatory agents that we'll discuss today. And those include the drugs that you see on this slide: indomethacin, sunelac, diclofenac, ketorolac. These are the most potent inhibitors of COX-1 and COX-2, and they're at least twice as effective at inhibiting inflammatory responses compared to aspirin. However, they're associated with many more adverse effects than aspirin. Indomethacin is useful in very serious cases of gout, very serious cases of either rheumatoid or osteoarthritis, but it's associated with at least 50% of patients experiencing some kind of adverse effect. Now, the mechanism of both the, of the indole acetic acids and the rest of the classes of the nonsteroidals that I'm going to talk about is non-covalent competitor inhibition of COX-1 and COX-2. So compared to aspirin, which causes irreversible inhibition of the two enzymes, the indole acetic acids and the rest of the nonsteroidals that I'm going to talk about act on the same enzymes, but they act in a different fashion. So they act on the same enzymes, but they act in a different fashion. The propionic acids are probably the most widely used class of nonsteroidal anti-inflammatory drugs. They include ibuprofen and naproxen. Again, they are competitive, non-covalent inhibitors of COX-1 and COX-2. They have very little specificity. They inhibit both enzymes in about an equipotent fashion. Ibuprofen has been studied extensively in the dental arena, and it's been found to be as good as Tylenol, which is acetaminophen, with codeine, and opioids. So ibuprofen is a pretty good analgesic, certainly in the dental arena. It's the gold standard. Naproxen's long half-life, again, and not one of you has avoided the commercials on television and in the radio. Naproxen's long half-life permits twice-a-day dosing, whereas with ibuprofen, typically it's a 4-dose per day regimen. Again, the phenamates and the oxycams, very potent nonsteroidals. They're not used quite as many. They're associated with substantial adverse effects. They are used in the inpatient setting, but again, their use is becoming relatively infrequent. They're much more expensive than the propionic acids, but they may be useful in circumstances where a patient is hypersensitive to one class. You can fall back and use a couple of these other classes in circumstances as need be. Let me talk for a minute about the so-called specific COX-2 inhibitors. The rationale for the development of these compounds was actually pretty interesting and pretty sound. So if the GI cytoprotection effect caused by prostaglandins is mediated mostly via COX-1, and the inflammatory responses and pain is mostly due to action of COX-2, if we had a compound that inhibited COX-2 but left COX-1 alone, it'd be terrific, because we'd inhibit pain, we'd diminish inflammation, but we'd leave the GI cytoprotective effects intact. And that should reduce the GI disturbances. However, very early on, there was a concern raised by many investigators that there would be cardiovascular effects that we needed to be aware of, because the action on platelets would be not manifest, and platelets make thromboxane mostly via COX-1, but a significant effect of such a specific inhibitor on PI2 production, prostacyclin production in the endothelium, because that's largely COX-2 mediated. So again, there have been several that have been on the market. The only one that's still on the market is celecoxib, sold by Merck. And one of the things you need to be aware of is that this is a relative specificity, right? So we have compounds like rofecoxib and celecoxib still on the market, but you can see it's really only about 10-fold selective to COX-2. These are COX-2 selective agents. These are COX-1 selective agents. And aspirin, naproxen, ibuprofen, again, are about equal potent. and the one that's on the market is really only relatively COX-2 specific. If you look at adverse and especially GI adverse effects from the most numerous to least, this is something that I think you need to be aware of. It's really COX-1 inhibition, and you might appreciate that because most of the cytoprotective effects in the gastrointestinal system are COX-1 mediated. So the most serious effects are guys that affect or drugs that affect mostly COX-1, and the ones that are relatively sparing ibuprofen. So these drugs are increasing in their clinical utility, and these drugs are decreasing in their clinical utility directly due to the inverse relationship with adverse effects. Let's talk for a brief moment about acetaminophen. You've talked about that. You will have a PBL case coming up and talking about acetaminophen. The precursor to acetaminophen that's actually given in Europe is called phenacetin. It's metabolized to acetaminophen. And acetaminophen is about as potent as aspirin. It's antipyretic. It has little anti-inflammatory activity. Okay, so remember that. It's actually not considered a non-steroidal anti-inflammatory agent because it has very little effect on inflammation. It's really good as a reducer of pain as an analgesic, but it's really a crummy anti-inflammatory agent. It has fewer GI adverse effects. It has fewer renal adverse effects. It has somewhat less platelet action, that is inhibition of platelet action. But in fact, in patients that are on warfarin and Coumadin, it's been associated with an increase in the INR, that is the propensity for bleeding. It may be used in children because there's no Ray's syndrome effect that's been described. And it may be it's really the only of these classes of agents that's recommended, albeit somewhat begrudgingly, to be used in pregnancy. Now, the problem with acetaminophen, and this gets the news every month or so, is acetaminophen-induced hepatotoxicity. Clearly completely dose-related and somewhat time-related, but the problem really isn't acetaminophen so much as it is the production of this intermediate NAPB or NAPQI, depending on what abbreviation you want to use for N-acylparabenzoquinonamine. This is a nasty molecule. It causes cross-linking of plasma proteins. It causes cross-linking of receptors. It does a whole bunch of bad things. Usually it's metabolized via GSH to the harmless mercaptopuric acid. But if GSH is limiting, i.e. if somebody's had a whole bunch to drink, or even acutely had alcohol ingestion sufficient to cause some liver damage and depletion of GHS, NAPBB increases to toxic levels. Yeah, and that causes really almost all of the toxic circumstances associated with acetaminophen. The antidote is IV administration of N-acetylcysteine with N-acylcysteine as an antidote, which basically acts via the same metabolic pathway and rescues GSH. Other anti-inflammatory agents that I'm not going to talk too much about include chloroquine and gold compounds. Still useful in certain circumstances where inflammation is uncontrolled and unresponsive to nonsteroidal anti-inflammatory agents. And you may see these compounds used on the board, and you may see these in some upcoming PBL cases. We're not going to specifically talk too much about asthma, but you've heard about asthma in previous components of this foundations, and lipoxygenase pathway inhibitors are quite useful for asthma. And they don't act on the cyclooxygenase pathway, they act on the lipoxygenase pathway. And there are two kinds of drugs on the market. One is xylitol, which inhibits the enzyme, the 5-lipoxygenase. It's pretty good. The problem with it is that it inhibits numerous P450s, so there are off-target effects associated with xylitol. But it's about as effective as inhaled glucocorticoids, which means it's a pretty effective drug in mild persistent asthma. Zafircolast, which is known as Singular as a trade name, and probably you've heard that on TV, rather than being an enzyme inhibitor, is a specific receptor antagonist. It's about as effective as the enzyme inhibitor, but it has many fewer off-target effects because its action is acting really on a fairly specific receptor. It is associated with headache and hepatic enzyme elevation. It's about as good as inhaled glucocorticoids in mild persistent asthma. So two components, two drugs that act on the lipoxygenase pathway and are very useful in the treatment of asthma. Now let me talk about a class of non-steroidals, of antiarrhythmic drugs that really is jumped onto the scene in about the last decade and has proven to be very efficacious in the treatment of mostly rheumatoid arthritis. So these are the disease-modifying antiarthritic drugs. Sometimes this acronym is DMAARDS, sometimes just DMARDs. DMARDs is sort of becoming more common. And basically the pathway that these DMARDs are acting on is the tumor necrosis factor pathway. So tumor necrosis factor is one of the most important cytokines. IL-1, IL-6, and TNF are the most important cytokines in mediating the arthritic response. And the drugs that are on the market include these four. There actually are a few more, but these are kind of prototype drugs. And adalimumab, infliximab are antibodies that bind to TNF and prevent its finding its receptor. Etanercept is a very clever molecule that basically takes the binding region of the TNF receptor, and it's a fusion protein with an antibody. Again, what it does is it binds to circulating TNF and it prevents its interaction with its receptor. And another component of this pathway, it's not really it's an anti-TNF drug, is anacerna, which is a recombinant IL-1 antagonist which inhibits IL-1, and by inhibiting IL-1 you can inhibit the release of TNF. Other targeted antigens that have antibodies that are specific to the cytokine pathways you've learned about include CD2 antagonists, CD20 antagonists, and IL-6 receptor antagonists that are mediated via antibody reactions and prevent stimulation of T cells mediated via those target receptors. Associated with the use really of any of these DMARDs is increased risk of infection. They're not general immunosuppressives, but they do increase the risk of infection, so you must screen for TB prior to use. And obviously any circumstance of TB infection precludes their use completely. Black box warning for lymphoma, and there's a low frequency of lymphoma associated with DMARDs, but it certainly is present and it can be fatal. Now, the second major class of drugs are the steroidal anti-inflammatory drugs, which are really what we're talking about here, are the glucocorticoids. And those include, as prototypes, there are probably 20 glucocorticoids on the market now, but they include cortisone, cortisol, their friends prednisone and prednisone, dexamethasone, triamcinolone, betamethasone. You've heard briefly about some of these drugs. These drugs have a classic nuclear receptor mechanism of action, that is, they enter the cell. They bind to a receptor which can be either intranuclear or cytoplasmic. The glucocorticoid receptor is cytoplasmic. It translates and is transferred into the nucleus and binds to glucocorticoid response elements, that is a DNA sequence that specifically interacts with the DNA binding component of the receptor. And that complex causes vast changes in what's happening on the promoter and ultimately increases in transcription, or in the case of glucocorticoids in their anti-inflammatory activity, a decrease in transcription of literally all of the components that I talked about, IL-1, IL-2, TNF, interferon alpha, and a number of other very potent inflammatory mediators. And I'm not going to talk too much about how they work, but I would refer back to this to think about this. Glucocorticoid receptors do a couple of things. They decrease the production and the transcription of a variety of transcription factors, most notably c-Jun and c-Fos and NF-kappa beta, which ultimately act to increase other pro-inflammatory molecules. So they act in a mechanism via a mechanism that's different but related to the mechanism of non-steroidal anti-inflammatories. They ultimately cause a decrease in phospholipase A2 activity via this intermediate called annexin. So they decrease the production of arachidonic acid. They decrease prostaglandins. They decrease the activity of COX-2, thereby decreasing the activity of prostaglandins. And they decrease the activity of a variety of other pathways that ultimately lead into either the lipoxygenase or the prostaglandin pathway. But importantly, and in clear distinction to the nonsteroidals, they decrease the number and activity of white cells. Now, I don't have all of the typical white cells, but lymphocytes are depleted. Certainly a variety of both T cells and B cells can be depleted. This particular series of studies was done mostly on B cells, and you can see circulating B cells are diminished by about 40% following dexamethasone administration, and a variety of natural killer cells are diminished really quite profoundly. So that's an important principle I want you to remember, that glucocorticoids cause a diminution in virtually all classes of circulating white cells, and that's emphasized here. So the anti-inflammatory effects of the glucocorticoids cause eosinopenia, monocytopenia, decrease in leukocyte function, a decrease in leukocyte accumulation, as well as a variety of the cytokines and other inflammatory mediators that I talked about. And those have both anti-inflammatory and immunosuppressive effects. We'll come back at later parts in the modules, in the upcoming modules, and talk about the immunosuppressive effect. So what I've discussed with you today are the action of really the most potent of the anti-inflammatory drugs, that is the non-steroidal anti-inflammatory drugs, the DMARDs, which are really, they're initially restricted to arthritis, but those exact same drugs are being used in a variety of inflammatory autoimmune diseases, Crohn's disease, for example, and a wide variety of other autoimmune diseases. And the glucocorticoids, which have really broad use. You've learned already about some of the adverse effects associated with the glucocorticoids, but again, very useful compounds because they affect both the soluble factors and enzymes associated with inflammation, but they diminish the white cell response too. If you have any questions, you know where my office is, I hope, and have my email address, so feel free to drop me a line. Thank you.